Good afternoon, everyone, and welcome to the Inner Circle webinar. I am Laura Gretzer, your host and the Director of Education for the Circle of Dental Excellence. Code goes by the acronym CODE. Sorry about that. If you're new to CODE, welcome, and I hope that you join us again. We offer monthly virtual mastermind sessions with expert guest moderators and several live multi-day in-person events throughout the country. They are also offered in a full virtual setting with multiple opportunities for continuing education. Joy, who's joining us today, is moderating a room on August the 20th during a mastermind session if you want to continue the conversation after today. We recently returned from our in-person Orlando event, and wow, I hope you guys got to catch up on the recap videos on our socials. They were so special, and it was such a great time. A lot of us had our families there, and we got to enjoy some social time with them as well. We'll be back in Orlando for a code feast at Mia's Kitchen on Wednesday, September 2nd, 7 to 9:30 p.m. I hope you guys get to register and join us. It'll be a lot of fun, a lot of networking, a lot of building your own communities. Our next in-person event is in New Orleans, December 3rd through 5th. We'll kick off on Thursday night with a live Back in 10 podcast and a welcome party, and then have 2 days of fantastic education featuring speakers like Stacy Singleton, Ashley Bond, Justin Winthrow, Rachel Wall, Rita Zamora, Jeff Gladnick, Alicia Diujuice, Katie Franklin, and Bev Wilbur. As a bonus, if there's any football fans, extend your stay a night because there's a game on Sunday. The Saints take on the Packers. You can find code on Facebook, LinkedIn, Instagram, YouTube, and circleofdentalexcellence.com to register to become a member. As a reminder, today's session is being recorded and will be shared on our YouTube channel shortly after today's presentation. The Q&A and chat features are open. I'll monitor the Q&A box and indicate to Joy that there's a question pending at an appropriate point. Now, once we get started, I will launch a quick survey for you that you can answer while we're getting everything prepared for you today. I am thrilled to welcome our guest speaker, Joy Lantz. She is a dynamic dental educator, consultant, and clinician who's passionate about prevention-focused whole body care. She brings an incredible depth of expertise to our session. She's been a certified orofacial myologist since 2017 and currently serves as the president of the International Association of Oromyology. Joy is also an international board-certified lactation consultant and the founder of Joy Lantz, Transforming Oral Health Today. She's here to show us how dental and medical teams can seamlessly collaborate on early screening for airway and myofunctional disorders. Everyone, please welcome Joy Lantz.
Hello, everyone. Thank you so much for hosting me. I'm excited to talk to your group today. So let me go through and share my slides here.
All right. I have launched a question for everyone.
Great. And pay attention to your chat because I am going to be asking some questions and I would love some feedback. All right, so today we're going to talk about integrating myofunctional therapy into your dental office. And in my opinion, I might be a little biased, myofunctional therapy really affects all disciplines within dentistry and outside of dentistry. I collaborate with many medical professionals as well, but myofunctional therapy is advantageous for orthodontic patients, periodontal patients, pedodontic patients, general dentistry patients. So it really touches every facet of dentistry. So really quick, thank you for the nice introduction. This is me. I've been a dental hygienist forever, since the 1900s. So I've been practicing a really long time. I am a board certified orofacial myologist with the IOM, and I do have my own practice where I practice both myofunctional therapy, and I'm also an IVCLC, which is a lactation consultant. So I work with patients from infancy, 2-day-olds, all the way up through patients who are in their 70s. So I help them rehab. I help them understand oral function and how it affects different things that they might be experiencing. I'm also a practice consultant, so I help practices understand how to integrate airway, frenectomy, myofunctional therapy, other topics that they might want to integrate into their practices. And that's kind of what we're going to touch on today. This is my disclosure slide. You can look that over. I do have a free study club. Also, if anyone's interested in learning more about myofunctional things, you can find that on my website. It's just myname.com. And now comes the fun. So I want you to tell me what you see on the screen in the chat box. What do you see? Orange circle. Very good. Anyone else? Usually I hear a sun. My husband said the Japanese flag, which is 100% wrong. An orange, which is great. That is what's on the screen, right? But what about on the outer part of the circle, right? What about the background? What about all the background noise that we maybe don't pay attention to? So when we talk about dental procedures, and I'm speaking for myself, right? Because I was this person. I'm so focused on my dental procedure when I would have a patient in my hygiene chair, right? We have so many things we have to do. We have to probe. We have to chart. We have to take intraoral photos. We have to check for cavities. We're checking for periodontal disease, right? We have all the things that we have to do that sometimes we miss all of the outer parts that also are contributing to our patients' oral health and, quite honestly, their overall health. So I wasn't trained in school to look for patients who were mouth breathers and how that was going to affect their oral health. Again, I was trained in the 1900s. We didn't talk about snoring. We didn't talk about sleep issues. We know that that's changed now. Yes, I marked in my chart if patient had crossbite, open bite, malocclusions, crowding, but I didn't necessarily know that that was a functional issue, right? And I certainly didn't learn about tongue ties. So these are all the outer things that we know now that are going to affect our patients in addition to other things that we're checking for. And these are things we should be looking at in our patients when they're in the chair. So when we talk about myofunctional disorders, the first thing to understand is what they really are. So it has to do with the muscles of our face. It has to do with movement patterns. It also has to do with habits. So when we have kids that are thumb suckers, pacifier users for a really extended amount of time, these are the things that get our muscles moving in a certain way and our facial muscles, tongues, cheeks, lips, chins. And if we're not using them properly, it can affect how we grow, how we develop, or how those muscles work properly. And form follows function. So if we're doing these things and we have these habitual habits, over time, it can affect what our teeth look like. So myofunctional disorders can include, we talked about these, we're going to continue to talk about them, thumb and finger sucking habits. Now, I've even had adults that are sucking their thumb. So if you're seeing signs, talk to your patients, ask your patients if they have habits. Habits of resting with their lips apart, mouth open, mouth breathers, people who can't keep their mouth closed. Forward resting posture of the tongue. These patients who are resting their tongue on the backside of their teeth, they're literally pushing their teeth forward out of place. These are the people that I usually see because they've had ortho relapse and they've been through ortho maybe twice, 3 times in their lifetime. And then our tongue thrusters and understanding why they're tongue thrusting and then what are the downward effects of that function. So I'm just going to touch on this very quickly. I got into myofunctional therapy because of my children. I have 3 children and they were born in the early 2000s, so you'll have to forgive me. These are old school photos that I've taken pictures of. But when I look at all my kids' baby pictures, they all look the same. And this is what my kids look like in their baby pictures. They are open mouth breathers. Their tongue is sitting on the floor of their mouth. And I did not know any better. I did not know that that was going to be a problem with their growth and development. Here's my daughter. She sucked her thumb until she was almost 6 years old. And we tried everything to try and get her to stop. And again, I didn't know it was going to be a problem. And here's my boys as they got a little bit older. We can see that gummy smile. And I've kind of compare this to super eruption. If we don't have the tongue stabilizing that maxilla, what happens is we start to get that downward growth and we see that vertical growth in the maxilla. So all three of my kids were in ortho at the same time, which was really great. And right before this is when I really started learning about myofunctional therapy. Why did they all end up like this? And why didn't I learn about this in school? And here they are a few years ago. So I mean, all this to say they ended up fine, right? We had our intervention, we got them taken care of, and they're fine. But for a lot of patients that we see, especially my patients my age in their 50s and their 60s and their 70s, they've been dealing with things for a very long time when it's really unnecessary. If we know enough to be able to intervene, then we can get them on the right path to help resolve some of their issues. So, what causes myofunctional issues? Again, we talked about habits, we talked about muscles. We can have healthy muscle function, we can have low tone in our muscles, we can have a lot of tightness and tension in our muscles. So, it can be a whole variety of things. And that can be part of the problem that makes diagnosing myofunctional disorders tricky because not everybody has the same symptoms, not everybody has the same thing happening. And that's okay. If we can unpeel it, then we can figure out what's happening. So we're going to talk about a myofunctional evaluation, but when I have a patient and I'm looking at their lips, their tongue, their jaw, their cheeks, all of their facial muscles to see where are we at, because that drives what their treatment's going to be for myofunctional therapy. So the three biggest causes of myofunctional issues are oral habits, structural restrictions, and airway issues. So we're going to break those down a little bit and talk a little bit more about them. So oral habits. We have patients who come in, I have 3-year-olds that are sucking their thumb. My daughter who sucked her thumb till she was almost 6. We have kids that walk into our dental office with a pacifier in their mouth at 3 or 4 years old. They have a finger sucking habit. I have kids who suck their tongues to help soothe them to be able to go to sleep at night, and that's a habit. Nail or cheek biting is another big one. The biggest one that we probably see in the dental office, though, is clenching and grinding. What percentage of your patients who sit in your chair are clenchers or grinders? 80, 90%? And what do we recommend for these patients? We recommend night guards because that's really all that we have. And that doesn't necessarily end the grinding, it protects their teeth, but they're still grinding on the night guard. They're still affecting all of the muscles that have to do with grinding and clenching. So we have patients who still have pain. So grinding and clenching, again, can be a sign of stress, which sure, we have patients who have a lot of stress. It can be sleep disordered breathing when they're trying to get air at night and they're grinding their teeth to wake themselves up to get oxygen. It could just be a habit. It could just be that patients don't know that they don't need to be clenching their teeth when they're sitting at their computer working. So that's what a myofunctional therapist is for, to help patients learn new habits, to help keep the pain away. Obviously, when we have grinding or clenching patients or patients who are having some sort of sucking habit, it's causing an imbalance in their muscles and it's going to create that domino effect. So I tell my patients if they are clenching their teeth all day, it's pretty much like holding a bicep curl all day. And what do you think is going to happen by the end of the day? Your muscles are going to be exhausted, and over time, you're going to be in pain. And it's not just going to be localized in your mouth, it's going to translate to your jaw areas and other areas of your body. Let's talk about kiddo things, kiddo habits. So again, we talked about extended pacifier use. We have kids that are using sippy cups for a really long time. The hard spouted sippy cups are not great. They don't teach our kids how to use their muscles properly to swallow. And then we have an epidemic of, feeding our kids soft foods. We have kids that are eating chicken nuggets, who are eating pasta, who are sucking food out of pouches to eat, and they're not really using their muscles to chew. And the muscles is what helps drive bone formation, and it helps give them the strength in the muscles that they need. So this is one of my patients who came in, and you can see exactly where that pacifier fits, right in that palate, right? So extended pacifier use is going to cause an issue because the palate's going to reshape. Ideally, as a myofunctional therapist, we want their tongues to be in their palate. And when we have low tongue posture, that's when we're starting to see high narrow palates. We have cross bites happening. So my passion is really intervening with kids because kids are more moldable. So if we're able to intervene and educate parents about these things, we can get them on a much better track and kind of resolve some of these things as they're growing. All right, another cause of myofunctional disorder is structural issues. So the biggest structural issue that we see are oral ties, tongue ties, lip ties. These are going to change the way those muscles work. If we have a patient with a tongue tie, they're not going to be able to move it the same way as someone who is not tied. So let's look at this picture of this patient. We can see he can't lift his tongue up to his palate. We can see that very distinct heart-shaped tip of the tongue. We can also see other things happening. So what other things do you see in this picture? I see crowding. I see chipping of those incisal edges. I see lingual tipping. I see restorations in the back of his mouth. So again, these are the domino effect things that I'm talking about. So when we have patients who have these tongue ties, they are not going to have good rest posture, meaning tongue resting in the palate, because they structurally can't get their tongue in the palate. They can't do it. These patients are usually tongue thrusters. Sometimes they can have jaw pain. A lot of times they will have sleep issues. And in children, tongue ties can, like we talked about, lead to malocclusion and craniofacial growth issues. So the tongue is really a good stabilizer, both for joints and for. And then the last thing we're going to touch on is obstructed breathing. So breathing is at the initial cornerstone of every myofunctional patient's treatment plan. We need to know if they're having restricted nasal airway breathing issues due to structural issues like enlarged tonsils, enlarged adenoids, maybe a deviated septum, or is it an inflammation issue like allergies? So again, this is another patient. These are the patients that we are seeing in our myofunctional offices. And these are things that you can clearly see from the dental chair. We can screen this patient for enlarged tonsils, which if we look at this picture, it's taking up the entire back of her throat. Do you think this patient has issues with breathing? Do you think this patient has issues with eating? So obviously there are some things that we can see, like tonsils, which we know are going to block airways. It's going to cause issues with breathing. There might be other things that we can't see, like enlarged adenoids or deviated septums, right? So that's part of what we need to tease out. And that's where our medical professionals really come in for us to lean on their support to co-treat patients. The other thing I want to point out is, what do you see in this patient's mouth dentally? What kind of things are we restoring or seeing in this patient's mouth that might indicate that we have some problems? I see very narrow arch, and I see a ton of stainless steel crowns. So if this patient has lots of decay and is having decay problems, how much of that is attributed to mouth breathing and not being able to keep her mouth closed, among other things? So in order to treat patients, the first thing we need to do is be able to spot what's happening in your patient's mouth. We need to be able to kind of have a screening tool to look at your patients. And I'm going to talk about typical things that you are going to see in the dental chair. So I want you to think now in a different lens about your patients that can't recline too far back in the chair. So that patient that you just saw with those gigantic tonsils in the back of her throat, do we think that that's a patient that might feel comfortable laying on their back? Or do we think that might be a patient that might say, I need to sit up in the chair. I need you to clean my teeth while I'm sitting upright. And why are patients asking that? Probably because she feels like she's choking, whether it's on the tonsils or with her tongue, but they can't breathe. If they can't breathe out of their nose and you're trying to work on them, it's going to cause a barrier. So they're not trying to make us crazy. They just don't feel good when they lay back. What about your patients that can't open wide? You tell them to open wide and they open their eyes really wide. So sometimes these are the patients who have issues with the muscles of their jaw. They might have issues where they're clenching all day long and those masseters are so tense and tight. And now you're asking them to relax those muscles so they can open wide. Maybe they just really can't do it and they don't even know that they're carrying all of this tension. This is typical, right? Your patients that gag either with x-rays or when you're trying to clean the lingual of 18 or get that distal filling done and they just can't handle it. A lot of patients I see who have oral ties, when they're tongue tied, number one, they have a compromised airway, so they don't feel comfortable having more things put in their mouth. Or if they're tongue tied and that tie integrates into the floor of their mouth, when we're trying to put an x-ray in or a mirror into the floor of their mouth, that's what's triggering that. It's the floor of the mouth is lifting up and then we're trying to push it down to get our tools in there. What about your patients who have that big tongue and you wish you had 3 mirrors that you could put in their mouth to retract their tongue away from the teeth to get in there? So I have a lot of patients in my myofunctional chair that unless they're looking in the mirror, they have no idea what their tongue is even doing. I will ask them to lift their tongue or move it side to side, and they have no idea what's happening in their mouth. Sometimes these patients have really low muscle tone and it's just kind of sitting there and they can't move it. But typically with these patients, it's not that their tongue is too big, it's that their mouth is too small. So then we have this big tongue that we're trying to whistle. And these are all the hygienist favorites, our patients with their really tight lips when we're trying to clean 24 and 25 and we can't get in there because they can't relax their muscles. And again, these are the patients that don't even realize that they're doing it. Typically, I have patients who compensate when they swallow. So when they compensate, that means that they're having to use their lip muscles, their chin muscles, and those muscles are then constantly tight. They don't even know that they're tight. They don't even know what they're doing with their swallowing. So they just have these really tense, tight muscles. And again, just like our jaw patient, we're telling our patient to relax and they don't even know what they're doing. This is just their normal. So just a different lens to see your patients with, right? All these people that we have in our charts that we make our little notes about, there might be a really bigger reason of why these patients are feeling this way in the chair. Some
Yeah.
things
So
I've
I do want to
noticed.
pop in with
Yeah.
some of these little poll questions because there were out of the respondents there were split 33% on everything about
Okay.
how confident they are in identifying the signs, right? So we're split in thirds on all of them between highly confident, somewhat, and not
Okay.
confident at all. So I certainly hope that all of these little triggers that I feel like are so common with so many of our patients
Yes.
are like, yes, yes, yes.
Yes. You know, you've had all these patients in your chair and
Yeah, or I hear the assistant complain about them. I hear the
yes.
hygienist complain about them. They're like, "Oh my
Yes.
gosh, she was just I couldn't get in. She was just
Yep.
clenching."
And you just get
So,
annoyed. But
yeah,
now it'll maybe give you a different perspective to understand why
yes,
they're acting like
I
that.
love this.
Yes.
Absolutely.
All right, some things in your examination that you might notice. Patients who have an increase in caries. I know when I was practicing hygiene, it made me crazy. I would have the husband and the wife come in, and the wife, floss twice a day, brush 3 times a day, did everything I asked. And the husband didn't do squat, and the wife was the one with all the caries. And it drove me crazy. But I didn't understand how mouth breathing had such a huge effect on oral health, right? So if we have those patients coming in and we can't figure out what's happening, maybe ask about mouth breathing. Maybe use your observation skills to see, are they mouth breathing? That's going to make a huge change in their oral pH and their microbiome that's going to cause these problems. And that goes hand in hand with our next topic, which is gum disease, right? If we have dry mouth, that's going to cause that biofilm to form faster. We don't have saliva to be able to clean it off. And then we have these patients with gum disease and, maybe bleeding in the anteriors, but not in the posterior. I remember these patients so clearly from practicing hygiene, and now it just makes so much more sense. Of course, tongue ties. right? A lot of people who are not trained about tongue ties will say, oh, you can stick your tongue out, so you're good. But that's not how we use our tongue. So when you eat dinner tonight, I want you to think about how much you use your tongue. What do you do with your tongue when you put the food in your mouth? What do you do with your tongue when you're chewing that food and needing to manipulate it around your mouth? What are you doing with your tongue when you swallow? And then think about this patient that you see who is tied literally to the tip of his tongue and how he would have to function differently. And now understand, when we ideally want tongues up to the palate when we swallow, we know this patient can't do that. So what's going to happen when the patient has to thrust their tongue forward to get a seal in their mouth? It's going to undo orthodontic work. It's going to affect craniofacial development. It can affect sleep quality. There's so many things that these oral ties can affect because our patients have to compensate. All right, ortho relapse. This is huge. We're seeing this in dental offices all the time because we're so focused on the teeth and we are not looking at other structures and what's happening. So patients with myofunctional disorders, even if they have fixed and removable retainers, our tongue is very strong and our muscles in our face are very strong, and things are going to move out of alignment even with retainers if our tongue is strong enough. And I see this happening all the time. So if we really want good retention, we need to pay attention to not only the teeth, but the muscles. When you have your patients in the chair who either have worn anteriors that you keep repairing those incisal edges, or if you have patients who have class fives, you have a patient come in and the doctor's putting in their chart that they need 12 class five fillings, are we thinking about why that's happening? Are they a clencher? Are they a grinder? And then why is that happening? Do we have instability in the jaw? Do we have grinding or clenching happening at night or during the day? Why are these patients continually coming in for the same treatment? And again, I remember this from hygiene days. It's the same patients, and those would just pop off and they'd have to come back in. Again, tonsils. I know back when I went to school, screening for tonsils really wasn't a big thing, but you can see how easy this is to be able to check for tonsil issues. A quick check in the back of the throat is going to give you a big surprise sometimes. So these enlarged tonsils are going to affect our patients and their ability to breathe, sleep, eat, and tolerate their time in the chair with us. So of course, we want to have connections to referring patients back to pediatricians, to their doctors, to an ENT, and give that patient resources for getting those looked at. Jaw pain. So I know we have tons of patients who come in with jaw pain, and it can be for a lot of reasons. I'm not saying it's always myofunctional therapy is going to be the issue, but I will say patients who have jaw pain and just get a night guard, we aren't really looking at the whole picture because it's not just teeth that it's affecting. It's going to affect the joint, the bones, and the muscles. So teaching patients how to relax their jaw and how to have stability in their jaw is going to help along with the night guard. So why should dental offices care about these myofunctional disorders? I bet if you really think about your hygiene day or your dental day, how many of your patients have one or more of the things that we've already talked about? Probably every patient.
Yes, I'm going to jump in with so many.
Yeah.
For sure. Now this was one of our questions too about screening, like who's
Okay.
screening for this, who has a protocol. So we're split. Everyone's split in thirds, right? So a third say yes consistently, a third are
Okay.
intermittently or case by case, and a third don't because they don't know where to start. So I really hope all of you get the answers
Awesome.
because
So we
like
have a
my mind
really
is just like I'm thinking of all the people.
we have an easy, short chair side screening that we're going to talk about. So you'll be able to integrate this hopefully really easily, and it's not going to add a lot more to your plate because I know that's hard too. So we know that obviously these myofunctional disorders are going to affect our patients, maybe not all in the same way, but in different ways. And just because it's common to that patient doesn't mean it's normal. So really remember that too. If they talk about breathing and they say, yeah, I've been mouth breathing my whole life, that doesn't mean it's normal. That's not normal. We want nose breathers. We want people to be able to eat whatever they want. I've had 40-year-old patients tell me they won't eat steak in a restaurant because they're afraid they're going to choke on it. That's a problem. We have lots of patients with sleep issues, whether it's sleep disordered breathing or upper airway resistance or sleep apnea. So, being able to address that is really important in screening patients in the dental office. And then, of course, just being able to have them tolerate a dental visit and not be uncomfortable. So this is what we're going to go through today. These are some screenings that you can do on your patients. The Epworth and the fatigue severity scale are two things that you can put right into your intake. You can just add them to your intake forms to get information about how patients feel like they're sleeping. The SPOTS assessment is a myofunctionally based screening. It was put together by one of my colleagues. Her name's Pat Brinkman-Falter, and I love this because it's so easy to look at these things chairside. These are things that you're already looking at. So let's go through these really quick. Let's go to the Epworth. The Epworth is 8 questions, situational for a patient to see how sleepy they feel doing normal things like watching TV or in a car when you're stopped at a traffic light. So it's just a scale, it's evidence-based, this has research behind it, and it's going to give you information that you can evaluate to say, does this patient need a little bit more? Do we need to dig in a little bit more and ask more questions about their sleep? Or are they answering 0 to everything and it's not an issue? This is the fatigue severity scale. So this is more regarding fatigue, meaning if they're having sleep issues, how is it affecting them during the day? So again, it's another scale. It's 1 to 7 for them to answer. And it's just a screener to give you information to know if you need to dive a little bit more and maybe ask more questions about sleep. Or again, if this patient is answering 1s to everything, then you're good. But things change, right? We know we have perimenopausal women. We have men whose testosterone levels are shrinking. We have other things that can be affecting this. So I'm not just saying it's myofunctional, but that's why being in touch with other healthcare providers is so, so important so we can, again, treat our patients as a whole. All right, this is Pat's SPOTS assessment. Again, I love this because I feel like it's really easy. So SPOTS is the acronym. The first S in SPOTS is for speech. So when you are updating medical histories, when you are talking to your patient about their vacations from this summer, you can be listening to what you hear. Do you hear a patient lisp? Do you hear a patient having difficulty with their R's? Those two sounds, our S's and our R's, are driven from the back of the tongue, meaning if we can't lift the back of the tongue due to low tone or a tongue tie, they might have these speech issues that you're going to be able to hear really easily while your patients are talking. So I'm going to show you a quick video, and you might not even, you're not going to hear this, but I want you to pay attention to what his tongue is doing because it comes so far forward that if you're looking at your patients when you're updating these things, you're going to see it right off the bat. So I must have taken that video out, but I have one for the last one. So I'll show you everything then. All right, P in SPOTS is for posture. So posture, you can walk behind your patient while you're getting them ready to be seated, and you want to see what's happening. Do they have a limp? Do they have, are they leaning to one side? And then the other thing is when you seat them, you are at a perfect perpendicular angle to them so you can see what's happening with their head posture, meaning do they have forward head posture? And ideally what we want to see with good posture is their ear canal being over their shoulder. That means that everything is in line. So when we have forward head posture, it's not only going to affect our head, it's going to obviously affect a lot of other things. Forward head posture can cause pain, obviously, in your neck, which we can see why from these photos, in the shoulders, in the upper back, can affect the jaw, because everything works together as a whole. And for some patients, this goes right down their full body chain. So getting that background is really important, but this is a good start because this is exactly how you're looking at their patients when they're sitting in the chair and you're right to the side of them. This is one of my patients, so you can see posture, you can see where her earring is, but you can clearly see that her head is not in line with her shoulder like we would want it to be. All right, O is for occlusion. This one's super easy. This is stuff that you're checking anyway. You're looking at patients' bites. You want to see if they have open bite, cross bite, and now we know the connection between myofunctional disorders and the effects that those muscles are going to have on occlusion. So we can have a variety of different things happening. We have this kiddo at the top who she was a thumb sucker. We can clearly see where that thumb fits right into those teeth. And then we have an adult patient, again, who was a tongue thruster and rested her tongue on those front teeth. And I want you to look at all the wear on those front teeth. And again, I want you to look at all the restorative work on those back teeth. And then we have our little kiddo in the bottom corner where she's just got a lot of lingual tipping and that 100% overbite, and everything is just really collapsing in on her. So not just notating what the occlusion is in your chart, but maybe taking it a step further and thinking about why. Why does this look like this and what's happening in their mouth to make this look this way? All right, the T in spots is for tethered oral tissues. So when I screen my patients, I look for tongues, lips, and buccal ties because all of them can cause different things. So again, tongue ties, they can all look different. So that's why we don't just look at what it looks like. That's the beginning part of it, but we're looking at the function piece of it too. So the very first picture, it might be a little tricky. It might not look like a tongue tie, like they can lift their tongue up, but what I want you to look at is the floor of the mouth. Do you see how when they lift their tongue, the entire floor of the mouth lifts up? And now I want you to think about all your gleekers who are spitting all over the place when they open their mouth. That's those people who are using the floor of their mouth to help them to compensate for lifting that tongue up. The middle picture, I feel like anybody can diagnose this, right? We can look at that. I want you to really look at how that's attached to that papilla between 24 and 25 and what's going to happen to that tissue if we don't address this tongue tie. And then again, the last tongue tie, that's a really short tongue tie. You can see that patient's having a hard time getting their tongue up to the palate. All right, the last S in spots is the swallow. So this is probably one that you are not screening your patients for. I'm going to show you a video. I know the video's in here for this, to ask your patient to bite with their lips open, and it's going to show you where their tongue goes. So ideally, we want our patient's tongue up in their palate for them to be able to swallow properly. And I want you to watch this video to see where this patient's tongue goes when he swallows. You see how it comes out between his teeth. And I want you to look at his lips and look at his chin and see how much strain he is using all of those outer muscles to get that swallow. So these are patients who cannot relax their mouth when we're trying to clean their teeth because he's using his lips, his tongue, his chin, everything is compensating together. So do you feel like that's easy? That's an easy chairside screening that you'd be able to use to at least know if your patient's having some kind of a myofunctional issue. I hope so. I hope it's easy. So obviously the effects we've talked about a lot of these myofunctional disorders. What do we see with patients who are complaining maybe about things that we aren't connecting to myofunctional disorders? If we have weakness, we're going to have issues with open mouth posture, either from weak lips or weak jaws. We're going to have issues with tongue thrusting. We're going to have issues with disrupted sleep, malocclusion, orthodontic relapse, caries and periodontal disease increase. So patterns over time, just like, in the dental field, we talk about carpal tunnel and we have these, repetitive injuries that happen. What happens when we have these repetitive things happening with other muscles in our body? We are going to see different growth patterns. We are going to see a decrease in our airway when we're developing, and just overall health, how people are feeling. So we'll talk about some of the effects of myofunctional disorders Feeding challenges, again, I work with a lot of babies, so if they can't lift their tongue up, they're going to have a lot of issues being able to hold on to a nipple, whether it's a breast or a bottle. They're going to have a lot of reflux. They're going to have maybe a preference for breathing through their mouth because it's just easier. We have oral habits. So we already talked about all of these in the beginning of the hour, but oral habits are a cause and an effect of myofunctional disorders. Growth issues. These are things that you're seeing in a lot of your patients. Crowding issues, narrow palates, ortho relapse, snoring, fatigue, mouth breathing. All of those are going to contribute to growth issues. And then chronic strain. So my adult patients that I see who are grinding and clenching have TMJ symptoms. Again, it doesn't just stop there. It's going to have these radiating effects to TMJ pain, ear pain, headaches, poor sleep, orthodontic relapse. So myofunctional science, why collaboration matters. Again, we've kind of touched on this a little bit, but it's not just for one person. We're not going to be able to address all of our patients' problems. If I have patients who are dealing with, musculoskeletal issues such as forward head posture, which is causing neck and shoulder pain, I'm going to refer out to either a chiropractor or a physical therapist. If I have a patient with enlarged tonsils, we're going to refer them back to their doctor or to an ENT that we have vetted. So we have a whole list of healthcare providers that we can be collaborating with and referring to. And I say it a lot. We're so comfortable in the dental office referring out to a periodontist or an orthodontist, but we think it's not our place to refer out to a speech language pathologist or a sleep physician. And it really is in our purview because we are seeing these things with our patients. So I'm just going to touch on how a myofunctional therapist can help all of these issues. If you want to do myofunctional therapy and you're recognizing all these things in your patients, how do we help these patients? What do we do for these patients? So one big thing is learning proper oral rest posture, which is tongue to palate, among other things. This is very general. We're going to help teach the patient how to reduce muscle compensation, which you saw in that video, right? When that patient swallows, they're using all of these muscles. When we swallow, we really should just be using our tongue. We don't need to use our lips and our chin to complete a swallow. And then correcting the oral phase of swallowing. This is really important, making sure the patient's chewing on both sides of their mouths, making sure that they're swallowing without thrusting their tongue forward and putting pressure on the teeth. So that's a general overview of how myofunctional therapists can help. For kids and adults, we always do breathing screenings. Again, if we have patients who cannot nose breathe, we really need to fix that first because, again, we've talked about how tongue to palate is the ideal resting posture. And that's going to seal off our mouth. So if we can't breathe through our nose, we have to breathe through our mouth. So being able to make our patients have strategies to be able to nose breathe is really number one. We always check for TMJ issues, right? We want to know, are patients grinding, clenching? Are they having pain in their TMJ? Do they get headaches? Do they have ear pain? And again, all of that can guide referrals if necessary or understand what's happening with that joint. Of course, muscles we talked about, we review tension or weakness, and this is going to set the goals for that patient. So there's a lot of stuff out on the internet about myofunctional exercises. That's not really tailored to what our patient needs. It's like saying every single patient that we see needs a prophy, and we know that's not right. We really need to do a full evaluation to understand what that patient needs. And then function. So we talked about watching the patient walk, how they stand, how they talk, how they chew and drink. That puts everything together so we can understand the mechanics of how that patient's function is working. So we're going to take a peek inside a myofunctional assessment, and this is going to break it down so you know the target for planning your patient's treatment. So it's very similar to what we do in the dental office, right? We need to have a full picture of what's happening first before we can set a plan for that patient. You're not going to go in and do any kind of cleaning on a patient until you have your probing numbers, right? So it's the same concept. So this is a checklist of some of the things that we're looking at. Typically, myofunctional evaluations take about an hour to an hour and a half because we're looking at so many things. So we're checking masseters, we're checking chins. We want to look at the TMJ, lips, cheeks, tongue, posture. How is your patient breathing? Do they have an open nose that they can breathe from? And we look at what their swallowing looks like. We're checking their ties. This is what lip ties look like. If they're tied really close to their teeth, it can cause diastemas, it can cause recession and stripping. So we're looking for these things in our evaluations. Of course, we're checking for tongue ties. They come in all shapes and sizes. So of course, we're checking function as well. We're doing measurements on patients. How wide can they open? This is the first thing that we look at and we measure. We're also checking overjet. So all these measurements are part of the evaluation. And again, a lot of times you're doing these measurements already in your chair. Overall myofunctional goals look like this. We've already talked about nasal breathing and how that needs to be number one. We have to have our patients have a clear open nose. We also want patients to be able to keep their lips and their mouth closed comfortably. We don't want them walking around with their mouth hanging open. We want their full tongue and their palate at rest gently. And then we want their tongue to palate for them to swallow properly without using all those other muscles. So we're going to look over a quick case study just to see what you see through your new lens now. So this patient, her name was Michelle. Her biggest concerns were jaw pain and neck and shoulder tension. She was referred from a dentist because she was diagnosed with a tongue tie. She came to see me because we like to do pre-work before a tongue tie release and then post-work for a tongue tie release. So we do a little bit of both. Her medical history included GERD and anxiety and depression, and she was medicated for both of these things. She said that she was really stressed out and she worked out a lot, and she thought that's where her neck and shoulder tension were coming from. She reported jaw pain and admits to grinding and clenching. She has to take melatonin to get to sleep. And at being 24 years old, she had GERD and had been medicated for about 5 years, which was really impactful to me. So she started being medicated for GERD at 19 years old. So here's what her tongue tie looked like. Here's the measurements that we do for the tongue tie. I can give you resources for that if you're interested in that. But that goes with the measuring tool, the range of motion tool. So she was diagnosed with an upper lip tie, a lower lip tie, and then a tongue tie. Here's the quick picture of what those ties look like. And then this is the evaluation summary of findings. So she had pain with touching her jaw joints. She talked about clenching all night long, discomfort upon waking. She had shifting with her jaw when she's opening and closing, and she reported temporal headaches twice a week. Now, for this patient, that was very normal to her. But from an outsider looking in, is that normal to have headaches twice a week? That's really not normal. She had a very difficult time moving her tongue in any direction without her mandible assisting her, so everything would move together. She had weak lips. When we tested her lips, they tested okay, but she had a hard time puckering. So again, those are going to be different exercises that we do with this patient versus someone who has very, very strong overused lips. She had a hard time doing her suction hold, so tongue to palate. And she had a scalloped tongue because she rested it in the floor of her mouth. So these are some of the photos that we take when we are seeing patients for myofunctional evaluations. It's a really good tool, not only for you to have for your patients. So I love intraoral pictures. Even if you'd only take bite pictures, I feel like bites change even every 6 months or a year. So you can really follow that within your dental program if you have an intraoral camera. But when we take facial pictures, we're looking for symmetry. We want the halves to look the same. And then we're checking the thirds of the face. So you can see in this picture that the lower third of her face is smaller than the upper third. So she's got some asymmetry, and this is really common for people. They have mid-face deficiency because they haven't had good growth of their jaws coming forward like they need to be. Here's some photos inside her mouth. It's hard to get vaulted palates from a two-dimensional photo, but she did tell me that she sucked her thumb until she was, I think, 6 or 7. And you can see the little bits of scalloping on her tongue. This is probably my favorite picture. She has a souvenir from being a thumb sucker. She literally sucked her thumb longer than her other thumb, which is hilarious to me. And these are her retraction photos, which quite honestly, if you look at this picture as a dental professional, would you think anything was wrong with this? It really doesn't look all that bad. So that's what I mean. These patients, it can be hard to diagnose these things sometimes because her retraction photos don't look like there's any issues happening. So of course, what we check for her is what that tongue tie looks like. You can see how her tongue tie has that bigger base at the bottom. We call that an Eiffel Tower attachment. You can also see when she moves her tongue, it does lift up the floor of her mouth. And here's a better picture of that. Now, this is the part that my patients think is kind of weird. I do have them bring something to eat and drink, and I watch them while they eat and drink. So I want to see a patient chew. I want to see what side of the mouth they're chewing on more, because what's going to happen if we have a patient who has a favorite side, that's going to affect their jaw over time. Are they able to keep their mouth closed when they're chewing? Or if they're a mouth breather, they're usually chewing with their mouth open. And do they chew enough? Or are they chewing twice and then swallowing their food? So I watch that first. The next thing I watch is what's happening with their bolus, which is their chewed up food. So I have a patient take another bite. I have them chew it all up. I have them gather it when they're ready to swallow. And then I want to see where that food is before they swallow. So that tells me a lot about their tongue mobility and how they're swallowing. So this patient in particular was thrusting her tongue forward to swallow because of that tie. And then we watch how patient drinks. So there's a lot more to it. This is a summary. This patient in particular, she pouches the liquid in the front of her mouth before swallowing, which means she holds it there. And that happens a lot for patients who are tied because they can't use the back of their tongue properly to protect their airway. So they'll take a drink, they'll hold it in the front of their mouth, and then they'll kind of reorganize everything, and then they will swallow it so they don't choke. So here's some of her chewed up food pictures for you to enjoy. And what I'm really looking for is for the patient to be able to gather that chewed up food in the middle of her mouth. And for patients who are tongue-tied, they have a hard time doing that. So they will tend to hold the chewed up food, the bolus, on their teeth, and then they swallow from their teeth. So what we wanted to do for this patient is refer her out, obviously, for body work for neck and shoulder tension. We started myofunctional therapy. We worked really closely with dental office that had CBCT. That doctor told her that she was going to need releases, like we said, of the tongue, the upper lip, the lower lip, and then possible expansion orthodontics, which I like all people to be able to have that as a possibility in the back pocket, because we never know. Patients might need more room in their mouth once their tongues are released. Myofunctional sessions. So what do these look like? Once the evaluation is done, we have patients come back and we work on different things at different times. We give them a week or two to work on these exercises. But for this patient in particular, we worked on breath work. We worked on her moving her tongue separate from her jaw, so being able to differentiate those two things. We worked on lip strength, jaw massage, and we worked on her being able to move her tongue and suction it up to her palate for her tongue tie release. Post-op goals for this patient was then being able to get her to move the back part of her tongue, which was previously tied, and get that to be able to feel comfortable resting at the top of the mouth. We want to establish proper rest posture, meaning, again, the entire tongue up in the palate. And we also work on forming a proper bolus. We work on proper bolus positioning and then swallowing with no compensations. The nice thing about this patient is she ended up going off of her GERD medication. Her GERD was from her tongue not being able to get up to her palate to form a full seal. So once she could seal everything off, she worked with her doctor and got off her GERD medicine, which was great. So these are some benefits patients report. I definitely have patients who come in and have oral ties and they tell me, I'm not going to get my tie released. So every patient is different and an individual, and that's okay. But even with myofunctional therapy, these are some improvements that patients will report. So better breathing. Obviously, if we have mouth breather versus nose breather, they're going to feel better as a nose breather. Improved sleep quality, hopefully by, strengthening the soft palate and keeping the tongue out of the back of their throat. Reduced clenching and grinding from teaching patients what proper oral rest posture should look like. Improved swallowing patterns, orthodontic stability, reduced oral habits, and then improved facial growth in children. So that's great. That's what we want. Practice benefits. Why would your practice, benefit from doing these things? You're going to have much better long-term treatment outcomes. If you're an office that's placing implants and you have a patient that's a tongue thruster, we're not going to be able to hold on to that implant for a very long time if they're thrusting on your work. Better preventive care. So if we have patients who can breathe through their nose and keep their mouth closed, that's going to improve at least part of the mouth breathing issue with the pH and the biofilm and all of that part of things. And patients trust you because you've done a little bit more. You've gone the extra mile. You've gotten down to the root cause of some of these issues. You're definitely going to attract a lot more health-focused patients. Patients are online reading all about, myofunctional issues and tongue ties and issues like this. So if they're coming in asking you questions and you have the answers for them, that's going to increase their trust also. Interdisciplinary collaboration. Again, I think this is huge. I think we are sleeping on this. I think we're sleeping on medical billing because all of these things are affecting our patients as a whole. Definitely going to differentiate you in the community. We have, dentists all over the place. This is going to set you apart. And professional fulfillment. It makes you feel good when you can help patients, especially if it's a problem that they've had for a really long time that nobody can figure out. So I love this quote. When dental teams begin to recognize the patterns behind breathing, posture, and oral function, you're not just treating their teeth anymore. You are changing the path of a patient's entire body, their whole health. And we talk so much about oral systemic health. And I hope you can see from today's presentation that myofunctional therapy and myofunctional issues, especially with patients, is going to affect not just their mouth, it's going to affect their entire body and how well they grow for kiddos and how well they breathe and how well they can hold their body in posture and feel comfortable. So it truly is an oral systemic pattern. So if you are interested in chatting more, you can hit the QR code. This is my Calendly link. If you would like to schedule a call, you can set something up if you have questions or if you want to talk more, or you can feel free to reach out to me via email. This is my email, joyelantz@gmail.com. Again, if you have any questions about the presentation or questions about a patient or anything at all, I'm here to help.
My audio is off. All right. And for everyone, I did put all of the links in the chat for you also. The mastermind registration, if you want to have a more open conversation with Joy during the mastermind session, she will be moderating a room there. That'll be a ton of fun because I feel like I could just dig into all of this right now. You can reach Joy on the website, which I have linked in there, her email and her link is there as well. So, wow. I hope, everyone was just spinning like me, thinking about all the patients, all the things that, we could certainly integrate with them and how to help so many of them who, just look at us like, well, it's always been like that. So
Right.
I feel like we have a place to send them, be like, okay, this is not normal. We can, help you with all of this, especially if they're receptive and, don't want to continue on in those habits they've had their whole life without knowing better, right? So, wow, I'm just like taking this video and everyone's watching it. The whole office, they're all gonna have to watch it. It was fabulous. So, I'd like to thank you for giving all of us this great education today. It has been wonderful. I'm over here doing all the things while you're talking about it. I'm checking my swallowing, I'm rolling my tongue around. So I hope all of you were too, because I was like, let me see, does that happen to me? Let me check. So please, if you want to, join in, join the conversation, hop on the mastermind August 20th at 7 o'clock Eastern time. Those of you who are on the call will get the certificate. You can watch anything that you missed. And then I will see you all again. I am scheduled another 2 weeks with Marvel and Navarro. We're going to go over some good oral systemic health. She is another hygienist as well. That'll be a good time. And I hope to see you all again soon. Make it a great day.
Laura is so frozen. Gonna shut us all out. Thank you so much, Joy.
Yes, thank you for having me. Appreciate it. Have a
Absolutely. It was
great one.
wonderful. You too. Bye-bye.
Bye-bye.